We are really excited to have everyone here today. So today I'm going to first just start out walking you through a little bit about DS Connect. I know most of you are probably very familiar with it, but we have a few new features that we want to highlight. And then we'll be joined by Dr. Dan Combs to talk about his research study with obstructive sleep apnea that used a DS Connect for recruitment. So as a reminder, this is being recorded. It'll be sent out to everybody who registered. There is a Q&A format, so only the panelists will be able to see your questions, and those questions will be answered at the end of this presentation. And we will kind of continue from there. So as a reminder, DS Connect is a secure registry, and we're hoping to gather information about a number of people with Down syndrome. So this is a resource hub designed to help individuals and their families connect with research opportunities across the nation. Additionally, we hope to be a hub kind of for access to resources that are collected and curated from the community. So this is the DS Connect homepage. So you can see the tabs across the top that take you to upcoming events that we've kind of talked about in the past, resources, and then research opportunities. So I'm going to give you a quick tour of some of the most recent additions here. And this is what you would see when you click on our resources tab. So you can see it's divided out by age. And within each age, there's 10 to 15 options that you can access through here by age group. So for example, if you select the newborn and school age screen, you'll have the option to explore 13 different resources. So you'll notice at the very top, though, is the American Association for Pediatrics Healthcare Checklist. So this checklist is available to everyone. It's a publicly available document, and it organizes recommended screenings and follow-up in a parent-friendly format. So when you access this document through the resources tab, it will include all of the ages. However, when you register for DS Connect and then complete the basic health information survey that everybody's presented with immediately when they register, only the checklist then that's relevant to your age is displayed on your dashboard. So this is a representation of the dashboard of a young adult with Down syndrome who's in that 21 to 29 year age group. So if you're within a year of the next age group, say 30, then the next age bracket will also appear for you. So you can kind of plan ahead. But these are available on your dashboard and available for you to download. So this is the pediatric checklist. So you can see that it gives recommendations. It's short and broken down by age. So this is the 1 to 5 year age group. And they give different recommendations in different health areas. And these are updated to be relevant as your child grows. But the American Association for Pediatrics checklist did kind of leave a gap as young adults transitioned into adult care. So the Global Down Syndrome Foundation stepped in to fill this gap and created the adult healthcare guidelines in collaboration with medical providers across the nation. So these guidelines translate recommendations into clear, actionable steps for adults with Down syndrome and are arranged in the same way as the pediatric guidelines, but are things to take with you and you can talk about them with your providers. So Global Down Syndrome has allowed us to post these on DS Connect. So again, they're available through the resources tab, but the ones relevant just for your age group are also linked on your dashboard. And then of note, these checklists are also available in 6 different languages and available at the Global Down Syndrome website. Going back to this representation of your dashboard when you join DS Connect is this other great feature called the Health History Snapshot. So this is an easy to read summary of all of the information that you've taken so much time to enter into DS Connect. We wanted to give a way to give this back to you really easily. So this snapshot condenses all of that key data into a kind of a 1 to 2 page PDF, depending on how much information you enter, that you can download with you and print out and take to your appointments. So This is just auto-generated information based on what you put into it. But the beauty of that is that you can come back anytime and update your information, which we hope that you do every year. But in that way, you can have something relevant to take with you, or share with any providers or that you need. And I would be remiss if I didn't mention our research studies page. So this is really one of the main goals of DS Connect, is to connect all of you with research opportunities across the nation. So these are studies who've been reviewed by our research review committee and curated so that we know that they're presented in a nice and clear manner. And you can access this on the DS Connect website underneath this research tab. And right now there's over 20 or almost 20 studies presented there. And then that wraps up my part, and I'd like to introduce Dr. Dan Combs. So Dr. Combs is an assistant professor of pediatrics and medicine at the University of Arizona. So he's board certified in pediatrics and sleep medicine, and additionally completed a fellowship through the Arizona Leadership Education and Neurodevelopmental Disabilities Program. So that's a LEND program. I'm sure some of you are familiar with that, during his pediatrics training. So he directs the pediatric sleep medicine program at Banner University Medical Center in Tucson. And he's also the associate program director for the University of Arizona Sleep Medicine Fellowship and the assistant director of scholarly projects at the University of Arizona College of Medicine. So Dr. Combs has received national research support from the National Institutes of Health, Patient-Centered Outcome Research Institute, so CORI, the American Heart Association, and other foundations, just showing the breadth of his work. His research is focused on the recognition and treatment of sleep disorders in individuals with special healthcare needs to improve their lives and the lives of their families. His NIH and PCORI funded research is particularly focused on the development of new treatments for obstructive sleep apnea to improve cognition and quality of life for individuals with Down syndrome. So DS Connect approached him because we featured the results of his pilot study in our newsletter a few years ago, and were able to facilitate recruitment for him for the follow-up study or phase of his study. So he's here to share more information about his findings.
Great.
Thanks, Dan.
Thank you, Angela. Gracias, Joaquin. Buenas tardes a todos. I'll just switch to English now, but that'll confuse the translator, hopefully. And then let me get my screen up. Okay. Okay. So I'm excited to be here and talk about probably what I spend most of my time doing for research, which is looking at sleep apnea treatment for people with Down syndrome. Goals today, talk about why do we care about obstructive sleep apnea for people with Down syndrome, and then focus really what are the current treatments and what are the future treatment options for obstructive sleep apnea in people with Down syndrome. And so broadly, so types of sleep apnea, when someone says sleep apnea, they're almost always talking about obstructive sleep apnea. Central sleep apnea is a thing also. Central sleep apnea, you have silent pauses. This is not particularly common, is somewhat common in infants and goes away as you get older, or is otherwise usually associated with neurologic conditions or neuromuscular conditions. There's a little bit of literature saying that this might be more common in kids with Down syndrome, but it hasn't really panned out. And really the focus is mostly on obstructive sleep apnea, which is pretty much from now on what I'll be talking about. So OSA presents snoring, choking, gasping are classic symptoms. In kids without Down syndrome, it's about 2%, 10 to 15% of adults, and is well associated with cognitive quality of life and cardiovascular effects in people with and without Down syndrome. Specific to people with Down syndrome, very, very extremely common. So infants, 30 to 50% prevalence depending on the paper. Children, 50 to 79%. And adults, 82 to 100%, depending again on what the study is. Importantly, many children with Down syndrome and OSA aren't noted to have that snoring, gasping, choking that's typically reported by parents. OSA tends to be more severe for people with Down syndrome. Because of this, the lack of symptoms in everyone and how common it is, screen with a sleep study is recommended by age 4. Unfortunately, the last time someone looked, about a quarter of kids have actually had a sleep study by age 4. So there's a lot of work to be done in terms of getting a sleep study for everyone with Down syndrome. Why is obstructive sleep apnea so common for people with Down syndrome? A few reasons. So one, anatomic structure. So if you look at people with Down syndrome, they tend to have like a relatively flat kind of front middle of their face, and then it's a little bit narrow. That ends up making your airway small. And so obstructive sleep apnea is your airway collapsing. And so if you start off with a smaller airway, it's easier to collapse. The tongue is relatively large compared to the airway. So again, it's more of a risk of obstruction. Big tonsils and big adenoids, which are kind of the classic cause of sleep apnea in children in general, tend to actually be even a little bit more common in kids with Down syndrome. The other big factor is low muscle tone. And so people with Down syndrome pretty much universally have low muscle tone. Your airway is muscles, and so it is also affected by that low muscle tone. When you fall asleep, your muscle tone naturally goes down, which is a good and normal thing. The problem is that when you go from low to very low, you can have spontaneous collapse of your airway, and that's where you run into trouble. So effects of OSA specific to people with Down syndrome. So these have all been demonstrated by various researchers. We know decreased verbal IQ, decreased adaptive function, which is your skills of daily living, which is a very important area. Decreased verbal fluency, so speaking less. There's some increased amyloid deposits in adults with OSA. That is thought to be a precursor towards Alzheimer's disease. And so there's the question of whether obstructive sleep apnea contributes to Alzheimer's development. That's kind of an ongoing open area. Decreased quality of life. Sleep apnea tends to make you tired and sleepy. Tired and sleepy people can't concentrate. You tend to be grumpier. Anyone who has kids has probably experienced both being tired from not sleeping yourself and what happens when your kids don't get good enough sleep. And even cardiovascular, there's a little bit of evidence that sleep apnea is associated with worse heart function, essentially. So what are the treatments that are out there more or less now? So standard treatments, so adenotonsillectomy, this is really ped specific. CPAP is universal. And then I'm going to touch on some kind of other treatment options that are out there, and then talk about what we do research in. And so adenotonsillectomy, so this is your classic tonsillectomy. So your tonsils are what you see in the back of your throat. Your adenoids are kind of up under your nose, and so you can't see those unless you use a scope to see them. Usually, almost always take them both out together, with exceptions. If you are a typically developing kid without Down syndrome that's not overweight, your cure rate is like 90%-ish with this. Like you get your tonsils out, your sleep apnea goes away, and you're good to go. Unfortunately, for kids with Down syndrome, that is not quite the case. So about half to 2/3 will have some degree of sleep apnea left after tonsillectomy. It does usually decrease OSA severity. So on average, you see a decrease of 50 to 65% in terms of severity. There's wide variation where some kids really don't get better at all. Some kids get totally better. But in general, it helps at least some. There are a handful of other ENT procedures that you can do as well that I'm going to gloss over. CPAP, so PAP therapy, so positive airway pressure therapy. This is just air pressure that's delivered through a mask and hose from a small machine. So it's essentially just a fan that compresses room air, and it uses it to keep your airway open from the inside. If you use this is great. So when it's used, OSA is essentially cured. So as long as the CPAP is on your face, it's 90 to 99% effective. And as long as it's on your face, you don't have sleep apnea. The downside, as I'm sure many people have experienced, is this is not the most comfortable thing to use. And so in a couple of studies looking at how well do people with Down syndrome use CPAP, one estimated adherence was 46%, so about half. I think that's a bit of an overestimate because my understanding is it looked like this is mostly people who were following up. So this is like the select subset who were using CPAP and kept coming back to clinic. One trial showed about 2 hours per night of average usage. I would guess clinically, like in my clinic, CPAP use is probably like 20% in terms of kids using it all night, every night. So if you can use this, it is fantastic. It is the best treatment for sleep apnea out there. It's going to be the best treatment for sleep apnea out there for probably at least the next 10 years, if not 20 or 40 years. If you can't use it, that's where everything else comes in. Myofunctional therapy is speech therapy exercises that improve your airway muscle function that you do while you're awake. And so the idea is it's things like puffing out your cheeks, blowing through a straw, things like that. It increases airway muscle tone with the idea being that if your airway muscle tone is strong in the day, it'll be stronger at night. Unfortunately, it doesn't have a lot of proof that it works. There was one study specific to kids with Down syndrome where they actually had them come out to a camp for a week, and I thought this was a super cool study idea. They basically came out to like myofunctional therapy camp, did 45 minutes of this 3 times daily for a week. They had not quite 20 kids with usable sleep studies before and after intervention. And AHI is apnea hypopnea index, and this is just the measure of how bad is your sleep apnea. And it unfortunately didn't change at all. There's some argument that you need to do this for months and months to have much of a benefit. That's probably true. I think the realistic outlook for this is that if you can do this for 60 minutes a day, every day for forever, it might help with mild to moderate OSA, but that's really not a realistic ask for most families, or really anyone, in my opinion. So it might work in some cases, but is a huge amount of work, and you have to basically do this for forever. Anti-inflammatory medication, so montelukast can actually shrink your adenoids and has been shown to have some efficacy for sleep apnea in kids specifically, not in adults, just in kids. And then things like Flonase, intranasal steroids, can also shrink your adenoids and have a little bit of efficacy for sleep apnea. There's 2 studies of these in people with Down syndrome or in kids with Down syndrome. Unfortunately, neither really showed they worked. So the follow-up AHI was essentially the same as the pre-treatment in both of these, and so probably doesn't work, unfortunately. Palate expansion. So probably at least some of you on this call have either had palate expansion or have had a child get a palate expander. This is basically a little turnkey, and you turn this and it basically spreads your teeth apart, and then it makes the bone fill in that gap and it makes your palate wider. And so you can see here's kind of before and after. You can see there's a huge difference. There's some evidence this makes your airway bigger just because you're making your mouth bigger, and then that makes your airway larger as well. This might help with sleep apnea. There's no specific studies on obstructive sleep apnea for kids with Down syndrome. And so this is typically used cosmetically. A challenge with this is that usually for OSA treatment, that would be medical insurance would be paying for this, and most orthodontists don't take medical insurance. And so if you're doing this for cosmetic reasons, you may get a benefit. But there's not a lot of evidence that there really is a for sure benefit. So it's something that it might help, but there's not a lot of hard evidence to say, yes, it's going to help, definitely. So palate expansion is for kids. You really can't do that after past your teenage years because your bones are more or less set in place. Mandibular advancement device is the dental option for adults. This pulls your lower jaw forward, so it just pulls here forward. This works reasonably well if you're not overweight and you have mild to moderate sleep apnea as an adult without Down syndrome. There's no Down syndrome studies that I've seen for these devices. I've used them in clinic a few times. You need to have all of your adult teeth in, so typically you need to be age 16 or older. And so this can be used for older teenagers and adults. Again, it helps some. It pulls your lower jaw forward, and so if you have issues with TMJ, it can aggravate those. If you've had braces, it can potentially shift your teeth back out of position. And so I've found that adherence to these is pretty close to CPAP. Typically, your lower jaw kind of feels out of position for the first hour or 2 of the morning, and so it's not a totally benign therapy. It's kind of annoying to people. But that being said, there are people who love this, and it treats their sleep apnea, but it's not a universal solution. Hypoglossal nerve stimulation. So this is approved for people with Down syndrome specifically. So this is a nerve stimulator that improves upper airway muscle tone. So I'd mentioned that low muscle tone is one of those contributing factors. And so this is essentially they implant a little pacemaker battery here and run a wire up to your hypoglossal nerve, which basically pushes your tongue forward up and out of the airway while you're asleep to treat sleep apnea. This has been approved for adults for probably 15 or 20 years at this point, maybe 10, and was FDA approved 2 years ago in adolescents with Down syndrome. And so this is a study from a group based out of Harvard. And so they found that baseline apnea severity was 22 pauses in breathing per hour. On treatment, that went down to 10. Quality of life got better. Treatment adherence using this was actually quite good. So this is on the market and is an option. It's FDA approved down to age 13. The clinical trial went down to age 10. And I know there's case reports in younger kids. Kind of downsides of this, the battery pack has to be changed every approximately 10 years or so. The other issue that bugs me is that if you are nonverbal, so this pushes your tongue forward, and so you can feel the stimulation to a slight degree. And so if you can't explain that that doesn't feel right, that could be really distressing. Like if you can't express it, hey, the stimulation is too strong, it's bothering me. That being said, it didn't seem like that came up in the clinical trial. There are newer, fancier versions of this kind of in clinical trials. I don't know if any will ever be done for people with Down syndrome specifically, but this is one of the options available now. So GLP-1 agonist, so this is your Wegovy, so semaglutide, tirzepatide, all of those. These were originally diabetes medications and then got approved for weight loss. So these recently, tirzepatide specifically, was approved for obstructive sleep apnea. And so this was obstructive sleep apnea in adults without Down syndrome. Tirzepatide, which is Zepbound is the commercial name, that showed a 49% reduction in sleep apnea severity compared to a 10% reduction with placebo. This predominantly appears to work just by weight loss. And so we can see this top graph is the change in sleep apnea severity. And so you can see about 50% better here. And then this is change in body weight. And so what you can see is those really go pretty closely together, where the weight loss is probably what is driving this. And so if you are not very overweight, these probably aren't going to do anything for you. The main risk with these, or the main kind of side effect that usually stops therapy, is GI related. And so they can make you feel overfull, and just kind of like have like stomach discomfort. There's no studies of these for people with Down syndrome. But there's really no reason why they wouldn't work. But that being said, studies should hopefully be done. And so this is an option for adults with obesity. But again, there's no Down syndrome specific data for these. Important questions. So I mentioned all of those bad things. Does treating OSA actually make those things better? The answer is probably. And so in a handful of studies that have looked at this, people who used CPAP did have better quality of life and parent-reported neurobehavioral outcomes. There's a study looking at tonsillectomy, and that did show improved quality of life. And then there's also the same group out of Harvard that was running the Inspire clinical trial for adolescents with Down syndrome has a follow-up study looking at cognition that I believe is ongoing. But they published some preliminary results on cognition a few years ago. And in general, this is a very small sample, so only 9 people. Everything was going in the right directions, and you can see that intelligence score went up slightly, adaptive skills went up a good chunk. So all of these went the right direction. So that's why I say the answer is probably. What's been challenging as a researcher is if tonsillectomy is not very effective and people don't wear CPAP, if we don't have an effective OSA treatment, it's hard to show that OSA improves cognition or improves quality of life, because if half of your study group doesn't use your therapy, you're typically not going to see a difference from the people who didn't use anything, because half your group didn't use anything either. So that has been the challenge. I think in the next 4 or 5 years, we're going to see that the answer is yes, but we're not there quite yet. And then this is the research that we do here at the University of Arizona. So Ado-Oxy, this is a combination of atomoxetine and oxybutynin. These are both on the market already as FDA-approved drugs for different reasons. Atomoxetine is a non-stimulant ADHD medication. This increases norepinephrine, which has the happy side effect of increasing your airway muscle tone in non-REM sleep. Oxybutynin is approved down to age 6 for overactive bladder. This decreases muscarinic receptor activity, which leads to increased airway muscle tone in REM sleep. And so the two have the convenient effect of increasing your airway muscle tone, which, as I've mentioned, seems like that's one of the key features of sleep apnea for people with Down syndrome. And so this combination is known to increase upper airway muscle tone. In adults without Down syndrome, there's been probably 7 or 8 studies at this point, and those have shown more or less 50% improvement in sleep apnea severity. There's I believe, ongoing phase 3 and then one phase 3 study that just ended of something called 8109 or aroxybutynin and atomoxetine. That's a very similar medication that is hopefully going to get FDA approved in adults in general in the next year or two. And then this is from the first study of atomoxetine. This was in 2019. And this was the data that was out there when we originally started studying this for kids with Down syndrome. So atomoxetine in kids with Down syndrome. So we know that it targets muscle tone. We know that the nerve stimulator is effective for kids with Down syndrome, but it's a surgical implant, and so it has all of those risks and burdens of having that. And so essentially we said, is atomoxetine a non-surgical alternative to that? And so we have, at this point, 2 studies. One is still enrolling, and I'm going to focus on the one that has ended already. So we enrolled a total of 15 kids with Down syndrome for a 1-month study of 2 different doses of atomoxetine. And so the high dose was the same as what they used, adjusted for weight, in the original adult studies. Low dose was the starting FDA recommended dose of atomoxetine. And so in terms of side effects, so the really ones that have jumped out is fatigue and mood changes. Those are relatively common, about 20 to 25% of participants. Everything else is kind of hit or miss. Dry mouth seems like it's relatively common as well. But the fatigue and mood changes really tends to be the main thing driving therapy. But in general, these were mild. We had a single child reduced due to side effects, and that was behavior changes, irritability. And then one child had their dose reduced. But otherwise, adverse effects weren't enough to make people stop treatment. Looking at how effective was this, so the low dose had less impact. So I'm going to focus just on the low dose because that's what we've been looking at from now on. So this is kind of this thicker line is the average change. And see, on average, people went from about an obstructive AHI, so 8 pauses an hour, to about 4. And you can see there's a pretty big range in terms of a lot of people did pretty much the average, but you can see this kid did fantastic. This kid really didn't have much of a change. And so you can see there's a pretty good range of treatment response, which will come up later. So quality of life. So we went back afterwards and looked at only medication responders. And so atomoxetine is known to cause fatigue and irritability. Usually after about a month of treatment, this goes away. In our follow-up study, that's more or less what we've consistently seen because we're looking at 6 months of treatment. And so we wondered if, because we only did a month of treatment, are we still kind of in the middle of atomoxetine side effects? And so if we looked at only responders that had their sleep apnea improve quite a bit, did they have more of a quality of life improvement? Because in the overall group, we didn't see one. And so we pulled out people who had their sleep apnea improve by 50% or more. And then also their residual sleep apnea was less than 5, which is the pediatric definition for mild OSA, which you don't always need to treat. So about 40% of participants were responders. And we found that the quality of life, so we used the P2QL, which is a very common quality of life measure, was 14 points higher in the responders compared to the non-responders. For perspective, usually if you see a difference of 3 to 4 points in that score, parents will report that corresponds to like a meaningful improvement in quality of life. So this is a fairly significant quality of life improvement in the responders. Again, this was after the fact, and so doing this in a larger sample and not going back and looking at just responders is important. So our ongoing study that is currently still going and will hopefully will end this summer, is a 6-month study looking at obstructive sleep apnea severity, quality of life, as well as cognition. We've finished enrolling for the study. This will end in June or July of 2026. And so this is what we're currently looking at right now. And then I'm going to kind of take a side note. So just as an example of inclusion in research being important, something that we've seen from our ongoing study. So you may have seen this theme of pretty much everything makes sleep apnea about 50% better in terms of the new treatment. So the Inspire, the Atoxy. So you can see in the adults with Down syndrome and kids with Down syndrome, really very similar efficacy. We were hoping for better efficacy, but we will take the same. What's different though, so you see that's the same, but what's different for adults without Down syndrome, urinary hesitancy, dry mouth, and insomnia have really been the driving side effects in terms of what are the most common or limit treatment. In our studies, we've seen dry mouth, but we haven't really seen a lot of urinary hesitancy. We've seen mood changes, which they didn't report in the adult studies. And then we actually added a questionnaire looking for insomnia specifically, just because that was one of the main treatment limiting side effects for adult studies. And so this is a small sample, so I wouldn't take this to the bank. But this is looking at, there's something called the Pediatric Insomnia Severity Index, which is a measure of insomnia severity. So things like, how often does your child wake up at night? How long does it take your child to go to bed? Things like that. And so from baseline, and we followed people's safety calls fairly frequently, what we saw is that instead of insomnia getting worse when we start medications, we actually saw insomnia symptoms improve quite a bit. And that seems like it's sustained. So this is the baseline, and then this is essentially a 60% improvement in terms of sleep maintenance. And you can see this is only a small subset of participants, but you can see it seems like it goes down and more or less stays down. And so I think this is a good example of just because you see the results in one group doesn't mean it's going to translate perfectly to the next. And so this is kind of an interesting side note. So then where are we going next? So I showed this picture previously. And again, you can see this green participant did fantastic. So they went from severe sleep apnea to basically no sleep apnea. The orange participant essentially went from severe sleep apnea to slightly better, but still severe sleep apnea. And so it would be great if we could tell in advance who's going to do this and get way better and who's really not going to get much better, because then we know that this might not be the treatment for you. There's a concept called obstructive sleep apnea endotypes. These are things that we can look at based on someone's diagnostic sleep study. So it's things like airway muscle tone, your control of breathing, where we can predict more or less like what's going to be the best treatment for you. This has been shown in some studies that it's fairly effective. So if we go to like a large study and pull out their endotypes at baseline, we can go back and say these are who should have responded, and that's generally correct. And so as an example, you can use oxygen for sleep apnea. It's about 30% effective in terms of reducing sleep apnea severity, which is okay, but not great. When you pull out people who are supposed to be good responders, that goes up to 70%. And so that's fairly promising. So we recently got a large PCORI grant that's going to look at this concept in people with Down syndrome. This will be kids and adults. One of the feedback items that we got from our current study was there are a lot of adults with Down syndrome who really don't have any options for sleep apnea treatment. And so we added adults to this current study. This is a multi-site study led by U of A. And so what this study will look like is somewhat similar to our previous design. People do a baseline sleep study, quality of life, and cognitive assessment. You then get randomized either to everyone gets the Atoxy, or what we're calling uniform treatment. So everyone gets Atoxy, or you get randomized to a group where we try to predict which of these you'll do better with, either Atoxy or oxygen. People who do better with Atoxy typically have a very different endotype from people who do better with oxygen. And so usually if one or the other would be expected to be better for you. And so we'd look at your sleep study and try to predict which of these we think would be better for you. Then you come back after a year of treatment and we repeat those same measures. And essentially we see, can we successfully predict who is going to respond to treatment versus just giving everyone the same treatments. So this is going to be 200 participants from across the country. So we're going to have sites in San Diego, Tucson, Chicago, Miami, and Philadelphia. This is opening hopefully in early February of 2026. And so you'll hopefully hear more about this once the study is open. But this is kind of where we're going in the future. So to summarize, the big take-home points, obstructive sleep apnea is super common in people with Down syndrome, is associated with worse outcomes pretty much across the board. Current OSA treatments are effective for some people with Down syndrome, but not all. There's lots of new treatments under development. I know there are other researchers working in this area, and I didn't talk about any of the things that they're doing. So there's a lot of things out there. And we're optimistic that using that precision medicine approach can hopefully help make new treatments more effective. So I will end with that. So thank you, our study participants, NIH and PCORI, providing funding. National Down Syndrome Society / Bluemind have been stakeholder partners with us for many years at this point. Sai Parthasarathy, Jamie Edgen, Paul Stewart, co-investigators at Arizona. Our lab staff is fantastic. And then I would like to point out that University of Arizona is really good at sleep medicine and basketball. So that is, I will close on that note and open it up for questions.
Thank you, Dr. Combs. That was great. A great overview and also very exciting results and very exciting news about this larger trial coming up. That's so exciting. What a fast progress. I'll be monitoring here the Q&A, see if there's anything that any of our attendees are interested in diving any deeper.
Yeah, a couple questions here. The first one for you is hypoxemia is also common in adults with Down syndrome. How does this complicate obstructive sleep apnea?
That's a great question. So the trick is figuring out, is the hypoxemia because of sleep apnea or not? And so if the hypoxemia is because of sleep apnea, then treating the sleep apnea is going to make that better. It can also be due to lung issues. And so if that is the case, you typically would need to do something like CPAP plus oxygen if it's a lung issue driving the hypoxemia. But it's very common, it's secondary due to obstructive sleep apnea. So I hope that answers that. That's a great question.
Great, thank you for that. We have another question that asks for clarification. Are you saying that the atoxy treatment increased fatigue and mood changes?
So those were commonly reported side effects. And so we essentially ask open-ended. So there's a few things we look for specifically. And then we also just ask open-ended, have you noticed any changes, like, or any like bad effects of the medicine? And so that would be, like my daughter was crying more at school than she usually did. Or he just seemed more tired than he did previously. And so I'm compiling that into like behavior changes just to make it interpretable. So that being said, when we look at the 6-month data, we actually see that happens in the first month and then typically actually resolves, which has been really neat to see.
Is atoxy fairly commonly known now, I guess, amongst clinicians? Is this something that families should bring up, or is this something that clinicians already know about?
It is still new and in clinical trials. And so I would say there are some clinicians who are very progressive in terms of prescribing practices, whereas other clinicians understandably say, like, let's see what clinical trials show. The atoxy is still, so it's 2 medications that are FDA approved, and so they are available, but they're not approved for the indication of treating sleep apnea. And so that's kind of the challenge, is that depending on how conservative you are, you might say, I don't want to just try this because there's not a ton of data, versus nothing else is working, so let's try this. And I don't think there's a right answer to that question. I think that's a very much like each provider, each patient question to sort out. But I think waiting for more data is entirely understandable. The 8109 that I mentioned, they, I believe, have finished one of their phase 3 trials and possibly the second. And so that would be FDA approved in probably a year, if I had to guess. And then I would imagine they would probably market that very aggressively because they've sunk a lot of money into clinical trials. So I think it would be very, very commonly known at that point. That would only be approved for adults, though, right now.
Some of these questions are pretty specific to individuals who are on this study. And Dr. Combs, we'll follow up with these with you. There's a number of other questions to present, but I just want to let the audience know that if they're really specific questions, go ahead and put them in there. But we'll probably follow up with you on these by email afterwards. Just so you know. One other
Okay.
question is moving on to the Inspire. Is this recommended for moderate OSA, especially looking at, we're thinking about adolescents?
It is. So the cutoff, the FDA cutoff is an AHI of 10.
Okay.
And so that is kind of between moderate and severe OSA. So usually for younger kids, we'll say an AHI of 10 or greater is severe. For teenagers, for adults, that number jumps up to 30 severe. So 5 to 15 is mild, 15 to 29 is moderate. And so it's an AHI of 10, which is somewhere in the moderate to severe range. So it sort of is recommended depending on what you're using to consider moderate OSA.
That would be more talking with their clinician as well.
Absolutely.
Okay. A couple questions about how to get involved in your larger trial in February.
Yes, that is great. So we have submitted for IRB approval, which is what we need to really advertise the study. So you will hopefully hear a lot about it. So NDSS is a stakeholder partner, so we'll hopefully be advertising, collaborating with them. Otherwise, so I glanced at the chat. So if you're in Miami, Ignacio Tapia at University of Miami would be the site PI there. And so we can't advertise yet because we're not open to enrollment. Clinicaltrials.gov is submitted, and so that should go live once it's approved by them. So we would love to have you, but until we have like the IRB approved materials, we can't advertise the study, if that makes sense.
And just for our audience, the IRB is an institutional review board. And so these are at different universities around the nation. There are some commercial IRBs, but they're an ethics and oversight committee, and they approve all of our research materials and make sure that we're representing things correctly and that everything is in order. So just a little background for you there.
Yes, thank you.
Yeah, absolutely. Any suggestions for anyone who can't do a sleep study? So we can follow up on those a little more personally as well. But is there anything, what do you do clinically?
That's a great question. So Ignacio Tapia and Chris Cello at CHOP have done some really cool work looking at home sleep tests for people with Down syndrome. Those are a lot less invasive because usually it's a small device. It's like the size of an iPhone. Connected to a cannula and an oxygen sensor that goes on your finger. And so you take that home, sleep with it there. If you can use that, it is not quite as good as the in-lab sleep study, but it is reasonably good, especially for adult-sized people. So that would be kind of the next favorite option. Past that, you can just do like overnight oxygen monitoring, which is not super accurate, but it's better than nothing, is what I'd say. And so that can be useful for, do I have no OSA or mild OSA compared to, do I probably have severe OSA? And so that's a lot less accurate, but that's probably the next best thing that you can do. I would be hesitant. So there's some of the ring-based home sleep tests. I would be hesitant to trust those. None of them are validated for people with Down syndrome that I know of. And they can give very wonky results.
Fair enough. Let's see, I'm trying to scroll through. Thank you for all of the great questions. And as a reminder, we will try and go through and answer the ones that we aren't able to get to, but we do have a couple more minutes here. Is there a reason that tonsil and adenoidectomies are really the first line treatment still, given some of the more recent research?
That is a great question. I think it doesn't have to be. So there's, especially like if you come to sleep medicine clinic, I think most people are happy to start CPAP. I think the issue is that it's something that we know is probably going to help at least some. Usually tonsillectomy tends to be done in younger kids, like closer to like age 5 or 6, where they're probably a bit young for Inspire. So I think it's understandable to have it as a first line option. If you think your child is going to do great with CPAP and you want to try that first, that would be entirely reasonable to talk to the sleep medicine provider about and give it a try. But I think it's just, it's a one-time surgery that we know is most likely going to help at least somewhat. And so that's why it's kind of stuck around as first line.
Thank you. Is there kind of a lower cutoff to when CPAP will make a difference? So saying 2 hours a night, using 4 hours a night, is there kind of a clinical guideline that you use?
There's more is better, is what I would say. And so you can look at the concept of essentially effective treatment. And so like you can look at if you're wearing CPAP for 8 hours a night, you're probably using it 100% of your sleep time. And so it's probably more or less 100% effective. If you're using it 4 hours, it's probably reasonably 50% effective, and kind of you can work the math out from there. Um, there's a cutoff if you're supposed to use it for 4 hours a night, more than 20 nights per month. That's like this arbitrary insurance cutoff that came out based on how long do people on average use CPAP. I think back in the 90s or late 80s. That number is like a purely just someone picked it decades ago and it stuck around. So that isn't super meaningful clinically, but more is better is the real answer.
That's fair. Let's see. We have had a few questions on BiPAP versus CPAP. Can you talk about the differences a little bit there, and then when
Yes.
Inspire might also be an option?
Yes. So CPAP versus BiPAP. So CPAP is the same pressure the whole time. BiPAP is a higher pressure when you breathe in and a lower pressure when you breathe out. Reasons that you use one or the other. Typically, we tend to use CPAP because it basically holds your airway open from the inside, and so that air pressure holds your airway open. You may switch to BiPAP. So if you have a lung issue where your ventilation is impaired, BiPAP will fix that, whereas CPAP is not going to do very much for that. Some people tolerate BiPAP better, so they just like the lower pressure when they exhale feels better to them. So often, if you're on higher CPAP pressures, we will switch to BiPAP purely for comfort. There's also a concept called treatment emergent central sleep apnea, where this happened in a subset of people where you use CPAP, your sleep apnea goes away, your obstruction goes away, but then you start having these long pauses in breathing. Using BiPAP can treat this central sleep apnea as well. So that's not super common. We'll see that on occasion. And those are kind of the broad main reasons that we would use BiPAP over CPAP.
There are a few questions in Spanish. So, Joaquin, maybe you'd like to translate those for us, and then we can get an answer to those next. But I guess my next question is, how do you determine readiness for, using a CPAP for children?
It's a conversation. I mean, there's no magic number. In general, if your child can't stand anything on their face, like all the patients where it's like they won't wear their glasses, they won't wear their hearing aids, like they will keep nothing on their face, they're probably not going to do super great with CPAP. And then I'll have some patients who are just kind of nonchalant and whatever happens is fine. And they might do great with CPAP. So I think it really is driven by parent judgment. I think if you know your child can't stand anything on their face, they're probably not going to do great. But if you are optimistic and want to try it, it's always reasonable to try it. One of the things that you can do that can be fairly effective is you basically start with like 1 minute at night. And so like you literally set a timer on your phone. You keep it on for 1 minute. You take it off. That's it. You don't push it any further. If they cry, leave it on. If they're totally fine, don't try to get more time. The next night you do 2 minutes, and then you do 3 minutes, and so on, until at some point it's on so long they're falling asleep, and then from there you're mostly good to go. But there's not. I haven't found any magic predictors of who's going to tolerate CPAP or not. I think parents are pretty good guessers. So I think that's really helpful, but I don't think there's a set age. We can do CPAP at essentially any age. Obviously, if you're older, it's a little bit easier because you can explain why it's important. So sometimes that can be helpful. But I think it's very case by case.
So go ahead, Joaquin.
Is that okay to address one of the questions?
Yes, thank you.
Yeah. So one of the questions is about the other form of sleep apnea, that central sleep apnea. Can you comment a little more about its frequency and Down syndrome, and whether it's associated with other co-occurring conditions or some other traits?
Yeah, that is a great question. So central sleep apnea is fairly common in infants. And so if you look at infants across the board, if you study 1-month-olds, essentially half of them will have central sleep apnea. That goes away as you get older. So the earlier studies have looked mostly at infants with Down syndrome and found that they had central sleep apnea. The challenge has been since then, it turns out that most infants have central sleep apnea. And so it's hard to say, was that important versus was it just you found the same thing in infants that happen to have Down syndrome that you would see in any infants? So I think it's hard to really say, does it specifically matter a whole lot for people with Down syndrome? I don't think there's a lot of evidence to kind of say one way or the other. So I think that's kind of an open question, but it doesn't. Most studies haven't seen a lot of central sleep apnea. So for our study, we actually exclude you if you have central sleep apnea. I think in 60 or 70 people we've done sleep studies and none have had central sleep apnea, got them excluded. So I don't think it's super common.
And then, there's a question that I hope the answer is yes, that whether hypoxemia is lowered when you use the CPAP.
Yes. So assuming that hypoxemia is because of sleep apnea, yes, it should hopefully go away. Again, if you have any kind of lung condition, that might not be true. But from a sleep apnea standpoint, yes, goes away, gets better.
You want to do a couple more, Angela?
Sure, we could do that. Dr. Combs, how often is the recommendation to get a sleep study to check OSA? Is this really kind of clinically indicated, or is this something that should be followed up on, annually, like the thyroid?
That's a great question without a real answer. So I will tell you clinically, if you have sleep apnea and you're on treatment, there's usually not a reason to get repeat diagnostic studies because we assume that you have sleep apnea. And if you're using CPAP, for example, there's really no reason to test. If you lose or gain a large amount of weight, that would be kind of the one exception. If you have a normal sleep study and you don't have sleep apnea, there's no great answer on when should I get a sleep study again. So I tend to use kind of gestalt of if every year I will usually see people back annually. If they come back and say, he's totally the same, nothing has changed. I will usually get a sleep study every like 3 or 4 years. If your previous studies did not show sleep apnea, showed really mild sleep apnea. If we know you have severe sleep apnea, that's usually not getting better with age. And so like for moderate to severe sleep apnea, really it'd be just getting a diagnostic study if you're not treated. If things are notably worse, like if you're like, like he can't stay awake in school, like things have gotten much worse. But there's not a guideline, do it every so often.
Going back to the atoxy treatments, are those compatible with other common medications that children with Down syndrome take? This one is specifically asking about stimulants for ADHD, but are there any other contraindicated medications?
No common ones. So there's a few older antidepressants that they can interact with. But for our studies, we've allowed people on ADHD treatment. And so we've had patients on stimulants and that hasn't been an issue. So common medications that people are taking, no. Obviously, if you're on atomoxetine, we would have to have you switch to the atomoxetine dose for the trial. But the short answer is no, unless you're taking a few unusual medications.
And then do clinicians usually accept a home sleep study for deciding treatment options?
That's going to be up to them is the short answer. But if it's a good home sleep study and you couldn't do a diagnostic study for a good reason, then I would guess that they would usually be fine with it. But again, like your Apple Watch, like the Aura Ring, like all of those ring-based ones, I generally find lie often, especially in children.
Let's see. We have just a few more minutes here. And as a reminder, we will try and get all of these questions to Dr. Combs and get answers back for you on them. Is there like a percentage number about the combination of Inspire and the Atoxy combo? How commonly is that used or?
Unknown. So we have not looked at that combo. So that's a great question. Yeah, it's a good question that we don't know the answer to.
Great, no worries. There's a question about if symptoms alone can be used to diagnose obstructive sleep apnea. Is it really the gold standard? You have to have a sleep study to get most of these treatments.
So the short answer is no. So you really would like to have a sleep study. That being said, probably 80% of ENTs, if you came in and you said that I snore and I stop breathing, or my child snores and stops breathing at night, would probably happily do a tonsillectomy. For a lot of the like CPAP or Inspire, it's very hard to get treatment covered without a sleep study. And so the short answer is no, because the sleep study is diagnostic of sleep apnea. With some of that wiggle room, like ENTs might be more willing to just do a tonsillectomy for snoring.
What I am hearing from a lot of people is that they would like some guidance on how to make CPAP more useful. They just aren't able to use it either in children or in adults. So thank you for that recommendation. And we could even think about doing that at a future webinar for DS Connect if that's something that's useful. So any other parting comments?
I think I glanced at, I wanted to make a comment on positional therapy because that came up, I saw, and that's actually a great question. So I'm pulling that one out. So positional apnea, so sleep apnea is usually worse on your back for most people. And so there's this idea of positional therapy where you basically wear a backpack or like use some kind of device to keep you from sleeping on your back. That's a really interesting emerging area. There's some data showing that maybe there is a positional effect. And so what's of interest to me is really like using that combination, because like sleeping with a fanny pack of foam on your back is costs like $10 if you make it yourself. And so if we can make sleep apnea like 50% better with medications, using things like positional therapy is another way of getting us from like 50 to 75% better. So I think it's a really interesting area. And it's worth, if you have your sleep study, like talking to your sleep doctor and saying, hey, is this something that we can try? So I do want to highlight that as kind of another cool area that's not very studied, but it's promising.
Well, and with that, I thank you, Dr. Combs, and we'll let Dr. Espinosa wrap up.
Thanks.
Joaquin, you're muted.
Of course. I was saying that all I have is gratitude, first and foremost, for Daniel coming today to share his wisdom, to NIH, the National Institutes of Child Health and Human Development, who sponsors and also is very involved in the design and performance of DS Connect. And of course, to all the attendees today and all the wonderful questions. Please have a great rest of the week. And a happy holiday season if we don't see you before then.